My name is Desi Sweet, and I am a pharmacist. I work locally in the Joplin area at a retail pharmacy. And today we're going to go over some basics about pharmacology, some pharmacokinetics, pharmacodynamics, and a lot of information about a lot of different types of drugs. So if you guys have any questions, please feel free to contact Jeff and he'll contact me, or you can call Stone's Corner Pharmacy and they will know how to get a hold of me. The first few slides here are kind of just objective slides, so I'm going to skip through those and let you guys read through those for yourselves. This slide talks about a basic introduction of what we're going to talk about today, medication administration, and how it's a defining element of the paramedic practice, but it's also not just important in the paramedic practice, it's important in basically every healthcare setting. A small mistake can cause a big error, so we always have to make sure we take every necessary precaution to make sure that things are right. Medications can either correct or decrease the severity of the illness, and they manage life-threatening conditions as well as substantially reducing patient discomfort, especially with like pain medications. Severe, often life-threatening consequences can occur, like we talked about earlier, if someone makes a mistake, and it's not just for paramedics, it's for every healthcare professional. At my job, if I make a mistake, it could hurt someone as well, so I always try to make sure that everything, when I leave, I feel the best about it, and if there's something that feels off, it probably is off, and I try to make sure that I can make that as right as I can before I leave. And I always tell the people I work with that if there's something that I'm going to lose sleep at night about, then I stay and try to make sure that it's right. The next part here is just defining the study of pharmacology. It is a study of how various substances interact with or alter the function of living organisms. So this is a historical perspective on medication administration. People have been taking medications for hundreds of years, and they started basically deriving chemicals from plants and animals and then using those to treat living organisms. And they have information that dates back to the 17th and 18th centuries. Some ancient remedies are still used today. People take opioid medications that are derived from opium tinctures that were used hundreds of years ago, and that's something that we still use in today's practice. Evidence-based guidelines are what assist clinicians on basically getting a treatment plan for a patient, and medications have to undergo extensive testing before they're approved. They have to be safe for the general public as well as have efficacy data for the general public. Medication and drug regulation. The United States has a comprehensive system of medication and drug regulation. The Food, Drug, and Cosmetic Act was passed in 1938, and it is where basically the FDA approves new medication and removes the unsafe medications from use. There's some drugs called the DESI drugs that were approved way back when. That's going to be things like phenobarbital that are older drugs that were basically grandfathered into the system, but anything that is a new drug has to go through these practices. The approval of a new medication typically takes several years. However, there's some drugs, if they're treating something that's a very unique condition or rare condition, sometimes they can push that through. Some medications are used off-label. Actually, a lot of medications are. And what they find out is when a medication is used for the approved FDA use, there are certain side effects that are actually beneficial to patients. So an example of this would be trazodone or Deseril, which is an antidepressant drug, but it was found that it had an adverse side effect such as sleep, and so now it's used for sleep or insomnia in patients. This is at a purpose that's not approved by the FDA, but they find out that it's beneficial for this use, and so a lot of times doctors will still write for it. And then also this can be a route of administration that's not typically FDA approved, but they find that it's generally safe in patients. The Controlled Substance Act was passed in 1970, and it classifies the different controlled substances based upon their abuse potential. So you have Schedule 1 drugs, which are have the most potential for abuse, and then you have your Schedule 5, which have the least potential for abuse, but there's still potential there. There is a mistake in this slide. Schedule 3 hydrocodone is now Schedule 2. The Percocet products are Schedule 2. Basically any kind of opioid medication now, except for Tylenol number 3 and Tramadol. Tylenol number 3 is a Schedule 3 drug, and then Schedule 4 includes Tramadol, which that may end up changing. I'm not really sure. There's a lot of different things happening with the opioids right now, so we'll see what happens with that. But I just wanted to make note of that mistake because I didn't want you guys to think that hydrocodone was Schedule 3, because it is Schedule 2, and we have to have, in the state of Missouri, you have to have a hard copy prescription for that drug. But Schedule 1 are your illegal drugs like heroin, marijuana, LSD, and then you've got your Schedule 2 controlled substances, your strong opioid medications, your amphetamines, methylphenidate, Adderall, and then Schedule 3. Basically, the only Schedule 3 that I can think of is your Tylenol with codeine. Because hydrocodone's not anymore Schedule 3. And then you've got your Schedule 4, which is your benzodiazepines, your diazepam, lorazepam, and then Tramadol. And then Schedule 5 is your narcotic cough medications and also Lyrica. The sources of medication. So medications are derived from plants and animals, as well as minerals and microorganisms. There's medications that are synthetic, which in this case they're made completely in a laboratory, and then there's semi-synthetic medications, so part of it's derived from a plant or an animal, and then the rest of it's derived in a laboratory. A good example of like a semi-synthetic drug is fentanyl, because part of it is synthetic and part of it is derived from an opioid plant. So sometimes in patients that have side effects to an actual synthetic drug, someone will give them a semi-synthetic to help avoid some of those side effects. Let's see here. So pharmaceutical companies control lots of different things. They control the concentration, the purity, the preservatives, and other ingredients in there. But when medications are distributed, we have to have a lot and expiration date, and that's just for any kind of safety issue, so that when a pharmacy dispenses this medication or you guys administer it and there's problems, we have a way to recall that, and if there's a safety issue, we can try to contact that patient. On your guys' end, I'm not exactly sure how that works, so I would be curious, but let's see here. So forms of medication. This slide's kind of just a basic slide. It has general information about the different dosage forms. Medications come in various forms, and I'll just kind of let you guys read through that slide, and if you have any questions about different dosage forms of things, you can let me know. Medication names. So this is one of the most tricky parts of pharmacy because drugs go by various different names. So you have your chemical name, which is the name that is used during the drug development phases. And then you have your non-proprietary or generic name, which promotes consistency and it avoids the duplication. And it typically contains a stem word. So my example for this would be like your beta blockers, which all have the stem O-lol. So you have your atenolol, carvedilol, bisoprolol. So they all have the stem O-lol. And then your brand or proprietary name is chosen by the manufacturer and selected for marketing. So with metoprolol, for example, the brand name is Lopressor. Now, the succinate form of metoprolol has a different brand name, and it's called Toprol. So there's lots of tricky stuff with medication names, and you just want to make sure that you attach the right name to it because it could be the difference in a salt form. This is an example of the different names. This one is talking about Lasix. So Lasix is the brand name. The generic is furosemide. And then the chemical name, and we'll see if I can say this without stumbling over it, but it's 4-chloro-N-furfuryl 5-sulfa-moyl-anthranilic acid. So that's the chemical name for Lasix. And then, every medication has those 3 names. So in your package insert, when you open up a drug, it'll have the brand name, usually the generic, as well as the chemical name and the chemical structure typically. Tall man lettering is to make drugs that are look-alike, sound-alike, easier for people like me that look at drug names all day long to make sure that we don't make a mistake. So here we've got diphenhydramine and dimenhydrinate. 2 very similar drug names, and so they try to highlight the areas where there is a difference. Another one I like to give an example of on tall man lettering is hydralazine and hydroxyzine. 2 very different medications, but if a mistake is made, it could hurt someone very seriously. Medication reference sources. So anytime you're using a drug reference, you always want to consider the reliability, whether it's printed, electronic, or both, and the depth of the information that's in there. We have to obviously consider accessibility and cost, how available it is to update it, and the size of the materials that were used. These are a couple different examples of drug references. I typically, I use clinical pharmacology on a day-to-day basis. There's lots of different ones. They give the USP&F and the physician's drug reference. Some other ones are Micromedics, Lexicomp, facts and comparisons, and the list goes on, but you just want to make sure that you're comfortable with using the drug resource that you use and that you think that it has reliable information. Package inserts are a great resource for information, and I also use those almost every day at my job. They include information on dosing, adverse side effects, contraindications, and routes of administration that are approved. However, if it's not an FDA-approved indication, it typically won't be on the package insert. Medication storage. So all medications need to have adequate protection. They need to be conveniently located for quick access, especially in your guys' profession. They need to be prevented from physical damage, should be placed in protective bins, and you need to be able to facilitate quick and accurate identification of them. Medication storage, you want to make sure that you avoid direct sunlight, extreme temperatures, and physical damage, and that's with all medication. Some medications are more sensitive to sunlight. Lasix is one. It has to be in a special type of bottle, especially the pills. I'm not exactly sure about the vials, but I think it's the same way. And then controlled substances, you have to have adequate security with controlled substances. You have to make sure that they're kept in a safe, locked key environment. In the pharmacy I work in, we have a vault that is locked with all of our Schedule II non-narcotics, and then the Schedule 3 through 5s are dispersed in alphabetical order according to the generic name in the pharmacy. And you have to keep adequate records, and this is a huge part of my job where I work to make sure that our narcotic inventory is spot on, and if there's a discrepancy, why there is a discrepancy so that we can document that. And then proper disposal precautions and making sure that you document all those. And like I said, every last milliliter or milligram has to be documented. Controlled substances are the target of tampering and diversion, and right now opioids are like the center of attention, and there's more and more spotlight going on them, and there's probably going to be more and more laws that come out as far as the different requirements and different dispensing laws that are made for me, and probably more guidelines as far as restrictions for the safety and security of these items. The physiology of pharmacology, so this is basically talking about that study of medications that are administered to produce a desired effect in the body. Pharmacodynamics is a specific piece of pharmacology that talks about the alteration of the function of the body as a medication is administered. And any medication can cause toxic side effects, especially as you increase the dose of them, and some people are more susceptible to adverse toxic side effects than others. Particularly our elderly population is more sensitive to the adverse effects of medication. So here we have the different processes of medication administration, and to me these are like the pharmacokinetic highlights. In school we were taught ADME, and this slide says ADBE. So you've got your absorption, distribution, your biotransformation, which, and how I learned that was your metabolism, and then your elimination phase. And these all encompass pharmacokinetics, which is the action of the body on a medication. The next slide here talks about your receptor sites. So your receptor sites exist in proteins connected to cells, and your receptors are activated by endogenous chemicals, which are already present in your body, and then your exogenous chemicals, which are the medications that we introduce or toxic foreign substances that come into your body. When a medication binds with a receptor, channels will either permit the passage of ions into the cell walls and be opened or closed. A messenger can become activated. A normal cell function is prevented, or the cell function begins. Medications that bind with particular receptor sites of target cells. So newer medications target only specific receptor sites. So a good example of this is going to be doxazosin, which is an alpha blocker, so it blocks all alpha receptors. And then you have tamsulosin or Flomax, which blocks your alpha 1A receptor and has less overall side effects that kind of trickle in with all alpha blocking, which is why tamsulosin is typically used for prostate problems. However, doxazosin is also used for prostate problems but has more adverse side effects because it doesn't target just that specific receptor site. Two types of medications that affect cellular activity by binding with receptor sites are going to be your agonist medications, which start that cellular response or alter cellular activity, and then your antagonist medications that prevent that activity from happening. They prevent agonist chemicals from reaching that cellular site so that the action is blocked. This is just a diagram that kind of depicts that. Agonist medication, so the affinity is the ability of a medication to bind with that particular receptor site. Binding with receptor sites is, like I said earlier, going to initiate or start that cellular action. The threshold level is the level at which that alteration of cell activity begins. So as you increase concentration of the drug, there's going to be increased effect. But eventually you'll reach a point where there's not going to be any more increased effect, and all the receptor sites will become occupied, and the maximum capacity of the cell is reached. The potency is the concentration of medication required to initiate a cellular response. So as potency increases, the concentration or dose required decreases. So there's certain drugs that require less of a dose to cause a response than others. Fentanyl is a very potent drug, so it causes less, or it has less of a dose to cause an effect than other opioid medicines. Efficacy is the ability to initiate that cellular activity in a therapeutic or desired manner. And this is the dose response curve. So here you have, if you receive no dose, you're going to receive no response. But as the dose increases, you're going to have an increased response until you hit that threshold. And when you hit that threshold, no matter how much more you increase the dose, there's not going to be an increased effect because all your receptors are occupied at that point. And then you have your antagonist medications, which bind with the receptor sites to prevent cellular action, basically. So they're going to prevent that agonist going into the receptor site to stop the normal cellular activation. There's competitive antagonists that temporarily bind with the cellular receptor sites, and usually the efficacy here is related to the concentration near the receptor sites. Also the affinity compared with the affinity of the agonist chemicals present. Then we've got non-competitive antagonists that permanently bind with the receptor sites and prevent the action of the agonist chemicals. The continuation of these effects until the new receptor sites or cells are created cannot be overcome by increased doses of agonist chemicals, and that's why they're non-competitive. Partial agonist chemicals, so they still bind to that receptor site, but they don't initiate as much cellular activity as a pure agonist. And they also lower the efficacy of other agonist chemicals. Alternative mechanisms of drug action. So there's other ways medications work, and other medications are used to target microorganisms like your bacteria and fungus, your lipids, your water-soluble substances, and your exogenous toxic substances. Antimicrobials target the cell walls, usually of bacteria or fungus. And then you have chelating agents. So a good example of a chelating agent that's common for the general population is levothyroxine, because it can bind to calcium or other cations and chelate with it, and then basically that cation is chelated with the levothyroxine and decreases the therapeutic effectiveness of levothyroxine, and obviously decreases the effectiveness of the calcium the patient takes. So both of those will be eliminated together because those two substances are bound together, and they're chelated together. So that's why it says here binding with heavy metals, because calcium is a cation, so it's a heavy metal and is going to bind to that levothyroxine, and then it will create a compound that can be eliminated. And then we've got sodium bicarb. Then diuretics, which obviously create an osmotic change. So a good example of that is Lasix or furosemide, which works on the loop of Henle, and basically helps with increased fluid and increases urination to help decrease the amount of fluid overload the patient has. And it alters the distribution of fluid and electrolytes. So you have to monitor potassium and sodium very carefully when patients are given diuretics. And electrolyte-based medications change the concentration and the distribution of ions in the cells and fluids throughout the body. You have to monitor when you give electrolytes, you have to monitor several different things. A lot of times one electrolyte is dependent on another electrolyte, so if one is low, you have to check another one, or the electrolyte will never actually all the way increase. A good example of that's like potassium and magnesium. You have to check both, or they'll never fully be repleted, the patient won't. Factors affecting response to medications. You have to look at the choice of medication, the dose, the route, the timing, the manner of administration, and you have to monitor the patient after the patient receives the medication. Age is a big factor. So you have your water-soluble medications, which require higher weight-based doses, and these have to be, usually these higher doses have to be administered to infants and elderly people, and that's because they have more water in their body than you or I typically. And then you have your fat and lipid-soluble medications, which require higher weight-based doses in elderly people. So it's really deceiving when you get an antibiotic prescription at my job and that little kiddo is receiving about the same dose of antibiotic as you or I, because for one thing, they do have a higher water amount in their body, and they also metabolize and eliminate things quicker, so they do receive a higher dose typically. Age is another big factor, so you have to consider the titration of medications for a pediatric or an elderly patient. You have to alter the metabolism and elimination, and sometimes that can prolong the effects for that patient. So with elderly patients, they sometimes metabolize things slower and eliminate things slower, so those effects of that drug are going to be prolonged. Patients at extreme ages are also disproportionately prone to medication reactions, which I kind of talked about earlier. Elderly patients usually typically experience a lot more adverse side effects, and some of that's because it takes them longer to eliminate the drug, and some of it is just because they're older and their body metabolizes things differently. Weight-based medication dosing. So a quantity of medication is multiplied by the patient's weight in kilograms, And some advantages of this are the amount of medication is proportional to the size of the patient. You can check the dose based on the manufacturer's guidelines, and you can calculate an appropriate dose for all ages and weights. Some limitations: you have to have the patient's weight in kilograms, which if you have it in pounds, you can calculate kilograms. You just divide 2.2, so you take however much they weigh divided by 2.2. It doesn't consider alterations in the distribution, metabolism, and elimination of that drug. And then some drugs are supposed to be calculated on ideal body weight. So some antibiotics have to be calculated based on ideal body weight, and so that doesn't take that into consideration. Environment is another big factor. So we have hyperthermia, which can increase the metabolism of drugs and reduce the amount of drug returning to the circulation. And then you have hypothermia, which impairs the effectiveness of medicines used in traditional cardiac life support. Genetic factors. So genetic factors are another big factor. You have to be careful when you give medications to patients with genetic disorders. Patients with pulmonary hypertension, sickle cell disease. This one also lists glucose 6-phosphate dehydrogenase. And another thing that's important to remember is all medications are metabolized by enzymes, and some enzymes take the medicine from the inactive form to the active form. And certain patient populations are not able to metabolize the medication and take it from the inactive form to the active form. A good example of this is codeine. Codeine is metabolized to morphine, and if patients can't metabolize it, they don't have the ability to metabolize this medication to the active form, it's not going to be efficacious. Sometimes patients are fast metabolizers and over metabolizers, and those patients are going to have increased effects from a smaller dose because they metabolize that medication so quickly. So that's another really important thing that this slide didn't have on there. And then you've got your family as a resource and the patient themselves as a resource for the genetic factors. Pregnancy basically affects everything. It affects the absorption, distribution, and elimination of all medications. And I'm going to let you guys read through all the different things that it increases and decreases, but it changes everything. And you always have to consider the effect of that medication on the fetus. Especially if the patient is in the first trimester. Typically that's when the medications have the most harmful side effects. So if that patient is in the first trimester, you really have to weigh the pros and the cons. I always tell people when they call me, I said, unless you absolutely have to have it and you think it's, life or death, especially if they're in the first trimester, then I recommend not taking it, because we still don't know a lot of information about what happens to the fetus in pregnancy, and I just personally don't think it's worth the risk. Therapeutic effects. So this talks about types of medication responses, and medication is selected based on patient's illness or injury, their signs and symptoms, and their complaint. And the condition should match the use and indication listed on the medication profile. The medication is administered in a dose intended to provide a desired clinical response. And sometimes that means repeated dosing, and these are capable of demonstrating cumulative action. Adverse medication effects. These are clinical changes that are not desired and cause harm or discomfort to the patient. Sometimes certain patient populations are more susceptible, once again, to adverse side effects. Patients that are on a bunch of medications tend to have more side effects, and patients who are have a bunch of chronic medical conditions typically are more susceptible to those as well. Also, elderly patients, once again, typically have more side effects with medications. The adverse effects can range in severity. Side effects can be desirable, and sometimes they'll be used to market an off-label use for a drug like I talked about earlier, and sometimes they're completely unexpected. Idiosyncratic is typically like an allergy to a medication, or you don't really know why that adverse effect happened. The types of medication responses. So here we have the Therapeutic Index, which talks about the median lethal dose of a medicine, the dose that causes death in about 50% of animals that are tested, and then you have the median toxic dose, which is the dose at or above that causes toxic effect in 50% of animals or more. And then the median effective dose is the dose at or above that causes your desired effect in 50% or more. The therapeutic index is the relationship between the median effective dose and the median lethal dose. The large difference is when the medication is safe. If there's a small difference, the patient has to be monitored. So there's certain drugs that have a narrow therapeutic index, and on those drugs you have to be really, really careful not to get out of that therapeutic window, because if you do, the patient's going to have very serious adverse side effects. There's lots of drugs that you have to monitor levels on, and phenatoin is one that we talk about later, but the phenatoin typically you have to monitor the levels on if a patient's on it consistently, and it's because the drug has such serious adverse side effects. Types of medication responses continue here. We've got immune-mediated responses, so patients that are genetically predisposed have an initial exposure or sensitization to an allergen, and medication sensitivity can occur following the first exposure to a medicine or substance, and a lot of times if they have it, it usually will have a worse effect after repeated exposure, so you typically want to avoid administering those medications to those patients. Medication tolerance. This is where certain medicines have a decreased efficacy when taken repeatedly, and those receptors are basically down-regulated. It reduces the available receptors for a particular medication. Tolerance, the big one with tolerance I think of is opioids, because patients typically after being on them for a long time get tolerant to them, and they have to keep increasing the dose to get an effect. Cross-tolerance, repeated exposure within a particular class of drugs that has the potential to cause tolerance to the class, and then tachyphylaxis, repeated doses within a short period of time that cause tolerance. Medication abuse and dependence. So these two types of medicine, stimulants and depressants, are typically the ones that are prone to misuse and abuse. And repeated exposure can cause that habituation, and prolonged or significant exposure can cause dependence. And abuse is a really big deal right now, especially with the opioid medication class, which would fall into that depressant category. Medication interaction. So basically medications interact with each other all the time, and when I'm at work I have to decide whether that's going to be detrimental to the patient, or that big of a deal, or something that I'm going to override and just talk to the patient about, or it's something that I'm just not going to worry about at all because it's really not that big of a deal. And that's one of the most difficult parts when you become a pharmacist, is trying to figure out what's important and what's not. But most medications do interact with each other. It's just whether or not it's really going to cause a detrimental effect to the patient that is what we have to weigh out. A major concern of this is incompatibility during administration. So there's certain drugs when given IV that are not compatible, so you have to make sure you check your drug references on that. And then medications can increase, decrease, or alter the effect of another medicine, and that basically goes into effect during our metabolism phase, because certain medicines are metabolized by the same enzyme, and so they're competing for that enzyme, which is what increases and decreases the concentration of that. Principles of pharmacokinetics. So as a medicine is administered into the body, it begins removing it. And the duration and effectiveness of the drug are determined by the dose, the route, and the status of the patient. It's also determined by the kidney function of the patient a lot of times. The pharmacokinetics section of a medicine basically talks about the onset of action, the peak effect, and the duration. The duration is related more to the metabolism and elimination, whereas you've got your onset and peak, which are more related to your absorption and metabolism. Your onset is how quickly that drug is going to reach effect, and then your peak is that maximum threshold, what concentration you're going to hit that maximum threshold, and then your duration is how long that drug is going to last in your system, which a lot of times we use HalfLife to determine that. The routes of medication administration. So the route of administration has to allow the delivery of the appropriate amount of medicine to the right location. And this can be determined by the physical properties and chemical properties of the drug, the routes available for the drug, and how quickly you need an effect. The bioavailability is the percentage of unchanged medication that reaches your systemic circulation, and that really varies based on the medication and the route. Here we've got the oral route and orogastric and nasogastric tube. The patient has to be responsive for this route. They have to be able to swallow. Here we've got a couple of things on the side that talk about the GI motility, the GI pH, and then the different things in the stomach that can affect the medication absorption whenever things are given orally. The endotracheal route, typically when I was in school, this wasn't taught as a reliable method, and here it says the same thing. But if a medicine is given this way, you have to usually give 2 to 2.5 times the IV dose. Intranasal is when liquid medicines are converted into a mist and sprayed into one or both nostrils. The absorption is rapid, and the bioavailability is 100%. So 100% of that drug is going to reach the systemic circulation. No need for needle stick injury. IV, once again, 100% bioavailable. Preferred method in pre-hospital setting, and it's when a catheter is inserted into the peripheral or jugular vein. And obviously your onset of action is quick because you're going directly into the systemic circulation. Limitations, access sometimes is difficult in certain groups of patients, and sometimes the procedure can cause pain or infection and is time consuming. Intraosseous is when a needle is inserted directly into the bone. This cannot be done in a fractured bone, and it generally cannot be left in place for longer than 24 hours. And these are just some different sites on the right side. Intramuscular, so these are medicines that are administered into your large muscle groups. The bioavailability ranges, but it's still high, 75 to 100%. And you have to confirm the medication is supposed to be given IM, what muscle should be used, which I don't know. On some medicines, I'm not sure if they specify what muscle to be used, and then a particular technique for injection, for using IM injection. Subcutaneous, we want to, here we're talking about medication that is injected into the subcutaneous tissue or fatty tissue. Some medicines are only indicated for sub-Q use, and they really have a slower absorption, so most of the time those medicines will last a little bit longer and can prevent some adverse side effects as well. And then you've got your dermal and transdermal. So these are medicines in patches. They typically release a small amount of medication over a longer period of time, and they contain a large quantity of medication in that patch. Sublingual route is the medicines that are placed under your tongue, like sublingual Zofran or sublingual nitro. Large doses are typically required. The patient still has to be conscious and alert. Sometimes antipsychotics are also given sublingually because patients will not swallow, so it's a good way to get those patients to take that type of medicine. And then you have your inhaled or nebulized type of medications. These are usually given via a nebulizer or a meter-dosed inhaler. The rectal route, it's preferred over the oral route if someone is unresponsive and having seizures or vomiting. It does have erratic absorption, so we're not really sure how much of it actually gets absorbed, but still we're in that 90% bioavailability range, which is good. Ophthalmic, and then we've got other methods of administration. It talks about hemodialysis here, but I don't know how much of that's really relevant. But it does state you shouldn't use any route that you're not trained to use, which is pretty much common sense. Distribution of medication. how a medication moves through your body. And this is determined by the chemical properties of the drug, the physical properties, and patient factors. And a lot of times the system of barriers prevents the introduction of foreign substances into the body. The medications must move through these barriers to get into the body. Osmosis is the moving of things from high concentration to low concentration, and it's used to enhance the distribution of certain medicines. It allows fluids to leave the intravascular space and enter the various tissues and cells. Filtration is the process within the body that is used to redistribute water and other particles. Epithelial cells, so your skin, always creates a constant barrier from things entering it. And larger hydrophilic and ionic molecules must find another route of entry. So they use pinocytosis, which is basically the budding of cell membranes to get things into the cell. You have facilitated diffusion, which moves things from a higher concentration to a lower concentration. And then you have active transport, which with active transport, you're moving things from a lower concentration to a higher concentration. So you have to have an enzyme and or some kind of biochemical messenger that helps with that process. And usually with that as well, it does expend energy to do that. Distribution of medication continue here. Medications have to move through capillary walls to reach some tissues. There's 3 barriers. There's your blood-brain barrier, your blood-placenta barrier, and your blood-testes barrier. And the blood passes freely through the capillaries in these organisms listed. Plasma protein binding. So some medicines are highly protein bound, and medication molecules typically attach to these proteins in the blood plasma. A common one for this is warfarin or Coumadin. Coumadin is highly protein bound typically. The concentration of medications can change as the plasma protein levels change, and if another medicine is highly protein bound, a lot of times those 2 medicines will compete and displace each other. Lipophilic medicines can be sequestered into the fat tissues of an obese person, and a lot of times these medications will last longer in this population group because they're released more slowly. The volume of distribution. So this describes to what extent the medication will spread throughout the body. Medicines with a low volume of distribution have higher levels present in the plasma, so that's going to be something like warfarin, like I talked about earlier. Biotransformation. So this is where we start to talk about metabolism of medicines, and this is where the medicine becomes a metabolite. With your active metabolites, these are capable of action. So this is going to be where the drug actually causes activity, and then your inactive metabolites are where the drug isn't going to cause activity anymore. Possible effects of biotransformation. So an inactive drug becomes active, like I talked about earlier. A good example of this is Plavix. Plavix or clopidogrel has to be taken into an active form to have a cellular effect, and some patients can't do that, so that drug isn't efficacious in that population. So, and then we've got an active medication that can be changed into another active medication, and then an active medication that's inactivated, and an active medicine that's turned into an inactive one that's just easier to eliminate. Most metabolism occurs in the liver through the cytochrome P450 system. And the kidneys, skin, lungs, GI tract, and other tissues can also biotransform, but most of it's in the liver. Most medicines are removed by the kidneys, and that's influenced by a variety of factors. There's a few medicines that are excreted into the feces, but a small percentage typically. And then we've got 2 patterns of elimination. Zero order kinetics is basically a fixed amount of substance is removed during a certain period, and then first order kinetics is what most drugs are, and that's where the rate of elimination is influenced by substance's plasma levels. Half-life. So half-life is a really big term in kinetics. It's basically the time needed for the metabolism or elimination of 50% of the substance in the plasma to be eliminated. It's the time it takes for 50% of that drug to be eliminated. And it's altered by factors such as disease states, change in perfusion, and medicine interactions. And a big thing with HalfLife is how well that patient's kidney functions, how well that patient's kidney function is, or how good that patient's kidney function is. So if they have poor kidney function, that drug is going to stick around longer and the half-life is going to be longer, which is variable in patients. Medications are administered at a dose and frequency equal to the body's rate of elimination. So a lot of times we'll use patients' creatinine clearance to know how fast a certain drug is going to be eliminated. A lot of times this will be used when you're calculating a vancomycin dose in patients in the hospital setting, and that way we can figure out how quickly that dose is going to be eliminated so that we know what dose to give and how frequent to give the dose. Elderly populations typically have a higher serum creatinine, and so their creatinine clearance is going to be less. So they are going to have to be given smaller doses and at a less frequent interval typically. Smaller amounts of medicine can be eliminated in expired air, but very, very small amounts. Reducing medicine errors. So medicine decisions are often based on memory and frequently occur in the context of stressful, life-threatening situations. Paramedics can make a cognitive or technical error, and any healthcare professional really can make an error. And I always try to double check myself, or if there's something I don't think is right, it probably isn't right. Most of the time when I feel something is off, I usually follow my gut, and so that's the best advice I can give you as far as that goes, but it never hurts to take a quick double check. Obviously, I don't work in the emergency field, and that is for a reason, because I don't handle emergency situations well. So, but you guys obviously do, and so you know how to handle those types of situations. These are the different things you want to check for to reduce medication errors. And it's always good to perform verbal readbacks of orders, to call out the medicine name and dose, label your syringes, check what medications your patient is on at home. You want to make sure you use a good drug resource and have your partner double check you. These are different things that can cause medication errors. I see these a lot at my job. A trailing zero, if there's no leading zero before a decimal point. These are chemical symbols. You think they're one thing, but they're not. And then here we've got some routes of administration that are used abbreviated, but could mean more than one thing. So it's best just to write it out if you don't, it just creates less error, especially in my job. I mean, you think it's one thing, but it's just not worth the risk. So it's best just to write it out, because there's too many abbreviations for things, and there's too many things that mean the same thing. Okay, so now we're going to talk about drugs that act on your sympathetic nervous system. Those receptor sites that exist in proteins connected to the cells throughout the body, and they're activated by chemicals. So with your heart, we have your beta-1 receptors, and when your beta-1 receptors are activated, it's going to cause an increased heart rate, increased force of contraction, and increased conduction velocity. In your arteries, you have your alpha-1 receptors, so when they're agonized, it causes vasoconstriction. And then in your lungs, you have your beta-2 receptors, which, when they're activated, cause bronchial muscle relaxation or bronchial dilation. This diagram just kind of depicts that very same thing. Sympathomimetic drugs, drugs that have alpha or beta sympathetic properties. And this is kind of the same thing. Let's see here. So there's two groups of beta sympathetic agents. We talked about that a little bit earlier, but beta-1 agonists and beta-2 agonists. Here we've also got your alpha agonists, so your phenylephrine and norepinephrine, which obviously when those are given, it increases blood pressure and it causes vasoconstriction. Your alpha or beta, depending on the dose, is dopamine. And then your beta receptors, which affect your heart and your lungs, drugs that affect those are going to be your epinephrine, which has alpha and beta activity, your albuterol, which is generally beta-2 specific, and then your isoproterenol, which is beta-specific as well. Sympatholytic or sympathetic blockers. So you also have drugs that block these receptors. Beta-adrenergic blockers. So they prevent those beta agents from exerting their full effects. This is going to be something like a beta blocker, like carvedilol or metoprolol. Here now we're moving into medicines that are used in airway management. So the first one we're going to talk about is a sedative hypnotic called etomidate. It's an imidazole derivative. It usually works as a single dose profound sedative. We usually only give one dose of this one, and it works quickly, and the effect is short, about 5 minutes. Ketamine. Ketamine is another sedative hypnotic. It's an NMDA receptor antagonist. It causes profound dissociation and anesthesia, can maintain blood pressure and heart rate with it, but it raises the intracranial pressure. And it can cause some bronchodilation. Benzodiazepines, so that's going to be things like lorazepam, alprazolam, those types of medications. And they're potent, anti-seizure, anxiolytic, and they do have sedative properties. Usually give high doses for adequate sedation. A lot of times in dentistry, they'll give triazolam to help sedate the patient before a procedure. They can be used to treat active seizures, but never want to be given during pregnancy. Pregnancy category D, and they're very harmful to the fetus. Flumazenil, it's competitive for the same GABA receptor that those benzodiazepines work on. And this has serious potential for life-threatening conditions, and it's more risky most of the time than beneficial. Your chemical paralytic agents. So these provide muscle relaxation. They facilitate airway device placement, prevent patient ventilator asynchrony during mechanical ventilation, and they bind with your nicotinic receptor sites. They're going to antagonize acetylcholine, which causes muscle contractions when released. And this diagram kind of just depicts that mechanism of action for you. Chemical paralytic agents, so your succinylcholine, it's a competitive depolarizing paralytic agent. It has quick onset and a short duration. Some of the adverse effects are listed there for you. And then we've got your non-depolarizing paralytic agents, which compete for that acetylcholine at the nicotinic receptor site. Two of these are your rocuronium, which is rapid onset, short duration of action, and then your vecuronium has a long onset of action. And then other medicines that are used in airway are your corticosteroids, vasoconstrictors, and your bronchodilators. Medications used in respiratory management. So now we're going to move back to the beta agonist medications. The big one with this one is albuterol. It's primary treatment for acute bronchospasm. It causes that bronchodilation and smooth muscle relaxation. It targets only those beta-2 receptor sites if it's selective, and if it's non-selective, it targets beta-1 and beta-2. Beta agonist medications. So here once again we're talking about albuterol, which is a selective beta-2 agonist. It's going to be typically nebulized or administered in a metered dose inhaler, and the levalbuterol is similar to albuterol, but it's basically a more pure form. It's an enantiomer of the albuterol, and it has fewer side effects, fewer beta-1 side effects, so it's typically used more commonly in the pediatric population because it has less increased heart rate, fewer beta-1 effects, just like that says. And then you've got your terbutaline, another beta agonist, and then epinephrine. But with epinephrine, we have to worry about alpha agonism activity as well as beta. Mucokinetic and bronchodilator medications. So the one that falls into this bracket is your ipratropium or Atrovent, and it antagonizes muscarinic receptors. In this case, we're antagonizing them to cause bronchodilation because under normal stimulation of muscarinic receptors, we're going to have bronchoconstriction. And then this medication also causes decreased mucus in the upper and lower airways. Corticosteroids are used in respiratory management. They decrease airway inflammation and they improve oxygenation and ventilation. They also have many immunosuppressant properties, but this drug class comes with a lot of side effects. So you want to make sure you know what health conditions your patient has, because it increases blood sugar, increases blood pressure, it can cause agitation, insomnia, and increased appetite, lots of yucky stuff. Now we're going to talk about drugs that affect the cardiovascular system. And the first class of medications we're going to talk about is the antidysrhythmic medications, which target cells within the heart to resolve the dysrhythmia